Good evening, everyone. My name is Muhaimin Hussein, and I am a first year internal medicine resident at UCF HCA College of Medicine, associated with the Osceola Regional Medical Center. Today, I am going to present a case called TB or not TB. Negative AFP smears not enough to rule out acute tuberculosis. This title is actually a tribute to the popular TV show House, where in season 2, Dr. House had a similar case where a patient came in with TB like symptoms, but no one was convinced that it was actually TB. So, to start off, some background. Tuberculosis is among the top 10 causes of death worldwide, much less in developed countries, but definitely still prevalent. The incidence of TB and the prevalence of latent TB in the US is about 9,025 cases a year and about 13 million cases, respectively. The morbidity and mortality incurred from TB make early diagnosis and treatment critical. Sputum acid fast bacilli, AFP smears, in other words, is an integral part of initial testing. So here we actually discuss a case of suspected case of TB with 3 negative sputum AFP smears, but positive bronchoalveolar lavage, testing confirming Mycobacterium tuberculosis infection. So first off, we have a case presentation here. A 21-year-old lady from Peru with no past medical history travels to the US and presents to the emergency room with complaints of acute onset productive cough, fever, and hemoptysis for 1 day. No other sick contacts that she knows of. She has no fever, no night sweats, weight loss, or any other smoking history whatsoever. Her vital signs include oxygen saturation of 99% on room air, blood pressure a little bit on the lower side with 96/56, temperature of 99.7, so borderline fever, with borderline tachycardia at 97 beats per minute as the pulse, respiratory rate of 20 times a minute. Physical exam unremarkable, and the lungs were cleared to auscultation. In any situation, just like this one, airborne isolation was still instituted while TB was ruled out. And the reason for that is she had hemoptysis, and of course, TB was on the differential as she was also traveling. And that's protocol at our hospital and most hospitals. So, due to the vital signs and hemoptysis, in the ED they ordered a CT angiogram to rule out pulmonary embolism. They actually ordered the CT angiogram before a chest x-ray was even done. This CT angiogram showed biapical infiltrates and a right apical cavitary lesion, but no pulmonary embolism. So complete blood count and metabolic panel were normal. Treatment for community-acquired pneumonia initiated with IV ceftriaxone or zithromycin. The initial 3 sputum AFP smears were negative. MTB culture was sent. And then afterwards, serum 1,3 beta-D-glucan, galactomannan assay, HIV screen, urine streptococcus, and Legionella antigens were also negative. In any case, also, just like vasculitis was also considered. For example, you can have rheumatological diseases such as Goodpasture syndrome that could present in maybe an atypical case or something like that. So of course we check those things as well. ANA antigen, rheumatoid factor, also negative. She continued to have low-grade fevers with nightly fever spikes, so TB remained on the differential. Even though she was being treated for community-acquired pneumonia, she was still under negative isolation because of the TB still being on the differential. At this point in the case, there were multiple physicians and attendings, including pulmonology and other people, who doubted that the patient actually had TB and began searching for other issues. They almost refused to do the bronchoalveolar lavage because they felt that it wasn't indicated. In any case, we were able to convince the attendings to get a bronchoalveolar lavage, then performed, and positive for AFP staining and MTB nucleic acid amplification test. So at that time, once it became positive, treatment was started with isoniazid, rifampin, pyrazinamide, and ethambutol, and continued undischarged. The MTB culture returned positive 54 days after collection. So for the imaging here, first off, we have this chest x-ray. Chest x-ray here, as we said earlier, it was done after the CT, but it was read here with bilateral upper lobe airspace consolidations and a stable upper lobe pneumonia. As we can see here in the bilateral upper lobes, we have some consolidations that are a little bit more abnormal, especially for a healthy 21-year-old lady. Next, we have the transverse view of the CT angiogram. Here we can see some interesting findings, but the initial CT, without knowing about the hemoptysis, per the radiologist report, read for bilateral upper lobe consolidations, findings may be concerning for chronic versus an infectious process. Once the medical team notified the radiologist of the hemoptysis, he took a second look at the imaging, and as you can see here, he also said that there is some evidence of focal cystic area / cavitation in the right upper lobe infiltrate. Tuberculosis should be considered as well. Continuing on the CT scan, if you see the AP view, you can see a cavitation as well in the right upper lobe in that region, which increases the differential and also convinced the pulmonologist to end up taking the patient for a bronchoalveolar lavage. Because these findings end up confirming the diagnosis of TB, we present the case that negative AFP smears do not rule out acute tuberculosis. And this is important because this patient started treatment for community-acquired pneumonia and so was almost discharged home after one episode of hemoptysis, but she was kept only due to the nighttime fevers and sweats that started once she got to the hospital. This patient was going to end her vacation soon enough and get back onto a plane to get back to her home country of Peru and believed that she was going to get adequate treatment. So it's a good thing that the medical team did not let her go. So TB, again, remains an important public health concern, and patients suspected to have TB must be placed on airborne isolation until active TB is definitely ruled out. Guidelines recommend through testing with 3 sputum AFP smears, MTB, and AAT, and culture in both solid and liquid media. Sensitivities for AFP smears and MTB and AAT are 67.5 and 85.2 respectively. In patients with either 3 negative sputum AFP smears or those who are unable to expectorate, combining BAL AFP smears and post-bronchoscopy sputum AFP smears have been showed a yield of 83.9%. It is thus important to use these tests in together rather than relying on one test alone. We conclude that for these patients who are at high risk for TB with a negative initial workup, it is reasonable to utilize early bronchoalveolar lavage, MTB and AAT, and post-bronchoscopy AFP smears for early detection and treatment of active TB.